Okay, hello. How are you? How is the study? Today we are going to start our discussion about abdominal surgery. I hope you can finish today. Everyone will share with me reading the question and the answer, and we will discuss related questions and the keywords in every question as well. Okay, so let's start with Dr. Doffer. Okay, start.
An 8-year-old boy of Caribbean descent presented with the periumbilical abdominal pain. He is vomiting twice and is refusing fluid. His temperature 38.1 centigrade, and the blood tests are as following: hemoglobin 9, white blood cell 13 multiplied by the 10 was 9. With neutropenia, what is the most likely diagnosis? Pancreatitis, sickle cell crisis, appendicitis, interception, and spontaneous bacterial peritonitis. I goes with the sickle cell crisis because he give me the geographical issue with anemia and the age. It is small age, so it's sickle cell crisis.
Exactly. So periumbilical abdominal pain,
yeah,
with vomiting, and also mild temperature with anemia, and is a very cardinal symptom with sickle cell crisis. So our option here will be sickle cell crisis. So this is so appendicitis will give you, frankly, he will tell you it is right iliac pain, and will give you some signs of tachycardia and nausea and vomiting. Interception will be will give you the cardinal signs with mucus.
It's away from 8 years.
Yes, and it is not in 8 years. Pancreatitis different.
Yes.
Central abdominal pain with back pain. Spontaneous bacterial peritonitis with immunocompromised patient, and there will no anemia will not be explained by spontaneous bacterial peritonitis. So sickle cell crisis is the best option here. Okay, so next question, Dr. Zaina.
Okay. With which of the condition listed below poor sign classically associated? Perforation of thoracic esophagus, acute cholecystitis, hepatocellular carcinoma, closed loop small bowel obstruction, acute diverticulitis. Occur with acute cholecystitis.
Exactly. What is both sign?
بيكون في hyperesthesia في السكابولا.
Okay, hyperesthesia over the tip of the right scapula.
Of the right scapula.
Of the right scapula, exactly.
Also another sign, lower Murphy's sign, also occurs in acute cholecystitis.
Exactly. So with cholecystitis, we have two main signs. Murphy's sign, which is tenderness in the right hypochondrium during inspiration, which lets the patient just hold his breath for pain.
Okay.
Exactly. The other sign is Bova's sign, which is a hyperesthesia over the tip of the right shoulder. Okay. Okay. We have two other signs, or some more signs we have to know, because this will be coming in next questions. We have what's called colon sign. Colon sign is ecchymosis periumbilical ecchymosis, and this happens in any intra-abdominal hemorrhage. In any intra-abdominal hemorrhage, very common with acute pancreatitis, rupture, ectopic pregnancy, or okay. The other sign is great Turner sign, which is flank ecchymosis, and this happens with any retroperitoneal hemorrhage, which is most common like pancreatitis, hemorrhagic pancreatitis, or sometimes happen with extraperitoneal rupture of the aorta. Okay. And the other signs is rebound tenderness in acute appendicitis, plus Rovsing sign, which is compression on the left side, which will push the colon contents to the right side, and this will elicit pain in acute appendicitis. Also, we have in acute appendicitis what is called obturator and psoas sign. Psoas sign happen with
Appendicitis.
appendicitis. Which type of appendicitis? Which position?
Pelvic.
Retroilial or retrocecal. With irritation of the psoas muscle during elevation of the leg against resistance, the patient will have pain. Another sign called obturator sign, which happens with
internal rotation of the
pelvic appendix. This with flexion of the hip against the abdomen and internal rotation of the thigh. Pain will increase due to irritation of the obturator internus muscle. This is the most common signs you will face during our discussion today. Okay, next question. Dr. Shi.
What type of stoma is most likely to be encountered in a 56-year-old man undergoing a low anterior resection for carcinoma of the rectum with a colorectal anastomosis? Colostomy. B.
And the colostomy, the patient is already with a colorectal anastomosis.
Oh, 8. Loop colostomy.
Not in common practice. You are doing a stapling or colorectal anastomosis, and you are going to do another incision and another cut in the colon.
Loop ileostomy.
Okay, loop ileostomy. Okay, and see, I don't know how many general surgeon is with us, but it is in doing a rectal or colorectal or colocolic anastomosis, we have to make rest for the defunctioning of the whole colon, defunction of the colon with a loop ileostomy. Okay. Let's just explain some here.
To prevent anastomosis leak.
Sorry?
To prevent anastomosis leak.
Prevent anastomotic leak. Okay, we have 3 operations. I just want to simplify.
Okay.
One, it is called loop colostomy, and we have one's called loop colostomy, and another one is called end colostomy, and have loop ileostomy, and have Eucus fistula. I'm just going to unmute Dr. Dofer. If there's anyone, I'll unmute him and have any background noise. Please just mute himself, please. Okay, so what is the difference here? I have a patient I'll tell you some scenarios we will face. Okay, I have a patient with an obstruction or a mass in the rectoanal region, and the patient comes with obstruction and abdominal distension. What I will do for this patient as an emergency operation. Okay, as an emergency operation for this patient, I'll do loop colostomy. So I want to relieve the obstruction to prepare the patient for a next operation. So this is to relieve. After I relieved this for the patient, I went for an operation, and I have two options for the operation. If I complete cut abdominal perineal, so I'll relieve the whole part of the rectum and the anus and the complete abdominal perineal or low anterior resection. So I'll go for what is called endocolostomy. Endocolostomy. So because I have no remnant distal portion, so I'll go for endocolostomy. If I went for the operation and I make an anastomosis, so I want to defunction for the colon, so I'll go for loop ileostomy like our scenario here. Okay, so I have two options. Even I remove the distal portion, so I'll end endocolostomy, or I make anastomosis, so I'll go for ileostomy. If I go inside and I found some infection and I couldn't, and I just made a part of the colon I resected, and there is still small portion of the rectum and the anus, and I couldn't close this distal part, and it's difficult to close it, like there is some infection, any difficulty to close the distal part, and I wanted to make it out, so I'll do what is called mucus fistula. So I'll make it outside, and then the distal colostomy, the endocolostomy will be also present. So together will be mucus fistula and endocolostomy. Okay, I know it is hard for some to understand this, especially on surgery. Anyone don't understand what is loop colostomy and what is endocolostomy and what is loop ileostomy and what's mucus fistula? Just raise hand, please. Dr. Ez. Yes, it is any particular part not clear, Dr. Ez, or all you can't understand?
I understand the principle by like a theory, but in the questions I tried before, I couldn't recognize or couldn't choose the right answer.
Okay, I just want anyone just open his editing tab to make delete or just remove any writing, please. Okay, what is the difference between loop? I just don't want to discuss this session. What is the cause of, yes, can we see a diagram? Okay. I have, this is the colon, sigmoid and anus. Okay. If I have obstruction here and the colon is distended, okay, so an emergency, what I will do, I'll do an emergency operation because now I couldn't okay, just okay. I want to relieve the obstruction in the colon before I go for the definite surgery. So I'll go inside here and make a cut like this. Okay, and I extrude externalization outside the abdominal wall, and I'll do what is like this. So I'll make some. So all the air will come from here, and I'll make for relief for the obstruction, and still I have the obstruction here for the definite treatment. Okay, this is the first thing for loop colostomy. I'll make it in the colon.
So can I add something?
Yeah.
Obstruction, it means that sometimes tumor. So all case with tumor, we should use the loop undiagnosed and definitive the extension. So put colonic colostomy, loop colostomy.
Emergency.
Only if the patient is obstructed.
Yeah.
Emergency obstructed cases. Emergency. If the patient is not obstructed, no problem. But a patient comes with abdominal distension obstructed, I have to do this. Okay. Then I was going to do the definite operation. I have two options for the operation. Even I'm going to remove this part only. So I'm going to remove this part only. So I have this picture at the end. I have this picture. What I will do, even I'm going to do an anastomosis between this and this. So when I did an anastomosis here, so I want to defunction all the colon, not to get any food or fecal matter or any gas inside. What I was going to do, I'll go for the end of the small intestine, and I'm going to do a loop ileostomy. I'll get the end at the terminal ileum, and I'll exercise apart and make what is called loop ileostomy. So the loop will be the same like this. Like this. This is loop. Loop. If I want to continue like this, so this will be loop. Okay, so fecal matters will come from proximal to go here and will not go for the colon, and this is the function of the colon. Okay, this is the first option that I did anastomosis. The other option, what will happen here, that I'm going to remove all this. So all this will be removed through an abdominal perineal surgery. So I have this picture. This picture, and this is completely removed. What I'll do, I'll take this portion and I'll put it in the abdomen like an end colostomy. So this will be an end colostomy because I have no distal portion here. So this will be a terminal or a permanent terminal end colostomy. This is another option. Okay.
Yes.
Another option happens in infection. Sometimes I go for this surgery and I remove this one, and there is some fecal matter and infection and sepsis here. So I couldn't, I have two options to do here. Even I open this like endocolostomy and close the distal portion with suturing. Okay, and this will be what is called Hartmann.
Yes.
Hartmann operation. This would be Hartmann. And Hartmann means closure of the distal segment and making an endocolostomy for the proximal segment to be closed later. In within 3 to 6 months. The other option in front of me, okay, if I couldn't, so This will be the same endoculus. If I couldn't close this portion, I couldn't close it, so I'll go for it outside the abdomen, like what is called mucus fistula. Mucus fistula means the mucus secretion will be excreted here, will be secreted outside the abdomen. So the end picture on the abdomen will be, in this case, okay, in this case will be like this, and this is the abdominal wall, and I have just only one opening for this one, and the other one is closed with suture, and this is Hartmann. The end picture with this, I have opening here and opening here. I look to the abdomen and I have this picture. I have this loop with the fecal matter coming from, and I have this loop which is closed, just secreting some mucus from here.
This is a mucus fistula.
What's called mucus fistula. So at the end, what is the difference between mucus fistula and loop ileostomy or loop colostomy? In the abdominal wall, if I have this with one opening, this will be loop colostomy or loop ileostomy. If I have this with separate loops, one is closed and one is continuous with the bowel, this one is called mucus fistula, and this is one is called end colostomy. Okay.
Yes.
I hope it's simplified and a little bit clear. Hope so.
Yes, clear.
Just it needs
imagining.
Yes, just need some imagination, and I'll make it simple soon through Telegram. I can send some picture after we finish the our lecture, so it can be a little bit simple as well. Okay.
Okay.
Okay. So it's clear. Unmute. Doctor, is it a little bit clear? Yes, please.
Yes, thank you, Dr. Rami. But what's the meaning of low anterior resection?
Low anterior section. And please, someone who opens the editing and just making some errors, please just make back for these errors or delete. Low anterior section and high anterior section. This depends on, I have a problem, tumor. This is the anus and this is the rectum. Okay. In surgery, we have, if I have any tumor within 10 centimeters from the anal verge, okay, I'll do complete resection with this part, with the anus and the closure of the anal area completely, and making an end colostomy, and this is called low anterior resection. High anterior section, it happens when I have the tumor above the 10 centimeters, so I can have a 10 centimeter here, or sometimes now with laparoscopic or endoscopic surgery, maybe less. So I can preserve the anal canal or part of the anal canal and just make excision of this part. Okay, and I can, in this case, I can make anastomosis. I can make anastomosis primary with the proximal and distal part, or I can just make an endocolostomy and Hartmann or mucus fistula for further reanastomosis. This low anterior section, I remove the anus with the tumor. High anterior section, I just remove above the anal canal, so I can preserve the anus. Okay. Clear?
It's clear. Okay.
Okay. I know it's hard for non-surgical, but try to it will be more clear when we go for different questions. Okay. Okay, next question, Dr. Sarah or Dr. Shi? First, Dr. Sarah or Dr. Shi?
A 23-year-old lady is persistently vomiting following a laparoscopic appendicectomy for a perforated gangrenous appendicitis. Imaging shows some dilated small bowel loops. What is the most appropriate course of action? Insertion of a wide-bore nasogastric tube. A.
Just try, please. Sorry again. So you said insertion of a wide-bore nasogastric tube. Yes, exactly.
Yeah.
What is the problem of this patient?
Elias.
Yes, Elias.
Exactly. Okay. So next question, Dr. Sarah.
A 78-year-old lady is admitted with a small bowel obstruction. On examination, she has distended abdomen and the leg is held semi-flexed. She has some groin pain radiating to the ipsilateral knee. What is the most likely diagnosis? D.
Splenic hernia.
Exclusion.
So which hernia it is related to the nerve related to the radiated to the knee? This is a question.
Exactly.
To the knee. Obturator hernia.
Yes.
Exactly. Exactly. Okay. We have two scenarios. One will tell you 78. Both of them will come with the same age, by the way, because femoral hernia and obturator hernia are very common in very old age. So he'll give you 70 or 78 or something like this lady admitted with small bowel obstruction. One of the points he will mention for you, the patient has groin pain radiating to the knee, and this is the key word for obturator hernia. The other one will tell you the patient has a swelling below and lateral to the pubic tubercle. Below and lateral to the pubic tubercle. And this will be a femoral hernia. Okay, this is the two scenarios you will face in a groin pain. Sometimes groin pain without swelling, and the other one will be groin swelling. Okay?
Yes.
Next question. Okay, Dr. Dafer, again.
Yes.
Anyone wants to share can raise hand.
25 years old lady presented to the RGP complaining of 2 days 5 upper quadrant fever and a wide vaginal discharge. She had seen the GP twice in 12-week complaint of pelvic pain and Baroni. What is the most likely diagnosis? So it is related to the upper quadrant gynecological problem. Appendicitis, adnexial pus, endometriosis, pelvic inflammatory disease, rupture, ectopic pregnancy. I go with endometriosis. Okay.
So, what's your answer?
My answer was C.
C, endometriosis.
Mm.
Okay, what is the key word for endometriosis here?
Female.
Yes.
Upper quadrant.
Okay. Okay. Endometriosis has a very common word and description. Cyclic pain. A mass with a cyclic pain, or an area with a cyclic pain. Cyclic pain gives us endometriosis. If he didn't mention any cyclic pain and bleeding at this area, so it is not endometriosis. Okay, so this patient is young patient, fertile, coming to GP, 2 days history of upper quadrant pain. Okay?
Yes.
Upper quadrant, right upper quadrant pain. So it is a hepatic pain. Mostly will be a hepatic pain. Fever, infection, and vaginal discharge. What is the most common cause for the vaginal discharge? Pelvic inflammatory disease. Vaginal discharge, when we'll face here, what he means with it is pelvic inflammatory disease. And any question you will face. So this patient is coming with a pelvic inflammatory disease. She come to her GP twice within 12 weeks. Within the last 3 months, she comes 2 times, complaining of pelvic pain and dyspareunia. Both of them, pelvic pain and dyspareunia, is a symptom and signs of PID, pelvic inflammatory disease. So what is the most likely cause?
Pelvic inflammatory disease.
Pelvic inflammatory disease. Okay. It is not acute appendicitis because it is not coming with vaginal discharge. It is not adnexal torsion because it will come with severe pain. Maybe the patient come with shock and vomiting and something like this. Endometriosis have a cyclic pain. Rupture ectopic pregnancy, he didn't tell you that there is collection and the patient is not shocked or the patient hasn't vaginal bleeding. Rupture ectopic pregnancy is associated with vaginal bleeding. But why does the patient have an upper quadrant abdominal pain? Okay, this is what's called Fitz. Please, sorry. Fitz-Hugh-Curtis syndrome. There is a transmission of infection intraperitoneal from the pelvis to the perihepatic space and making some fibrinous adhesion between the liver and the abdominal wall and the retrohepatic or the perihepatic space. So any patient with pelvic pain and young patient with pelvic pain, vaginal discharge, and right hypochondrial pain, this is called Fitz-Hugh-Curtis syndrome, which is a perihepatic inflammation. Okay?
Yes.
Next question. Whose turn? Dr. Zaina. Dr. Hanan wants to share. Dr. Hanan, unmute yourself. You want to share? Okay. Dr. Hanan, are you ready? Okay, Dr. Zaina, go ahead.
Okay. A 34-year-old man undergoes subtotal colectomy to treat fulminant ulcerative colitis. What type of stoma is most likely to be fashioned? Endocolostomy, loop colostomy, end ileostomy, loop ileostomy, and jejunostomy. End ileostomy.
Why?
لان انا هنا في اللي هو ulcerative colitis وهعمل subtotal تمام فهيبقى في بارت بس من الريكتم هو اللي هيبقى موجود.
Okay. Why you didn't make why you didn't make primary anastomosis?
ulcerative colitis وفالمنت فهيحصل leak.
Okay, and it is not in the option, by the way. So, okay, so subtotal, we removed most of the colon, and we just have a remnant of the, or a part of the ileum. So we are going to do exercise the ileum. So it will be endoileostomy, and we are going to close this like Hartmann operation, closure of the distal part. And then after the patient general condition improve, we may going to do what is called J-shaped pouch or iliorectal or ilioanal anastomosis as a final stage of operation. I just was going to anastomose the ileum with the rectum or anal canal. So I make what is called ilioanal anastomosis, and this is a final treatment after we the patient condition improve and the infection improves. Okay, so it will be an end ileostomy. Next question, Dr. Shi. Dr. Shi, unmute yourself.
A 45-year-old man develops a colocutaneous fistula following reversal of a loop colostomy fashioned for the defunctioning of an anterior resection. Perioperative gastrographin enema showed no distal obstruction or anastomotic stricture. What is the best course of action? Make the patient kneel by mouth and commence total parenteral nutrition.
Okay, anyone have different answer? No one gets the right answer till now. Maybe Dr. Daffer only.
يعني in cases of fistula we try first conservative treatment. Okay. Waiting for
so this is
closure.
okay. Okay.
It's not distal.
This is sorry.
It is not distally obstruction. So there is
exactly. If we have a fistula, especially when it is colocutaneous fistula. Anyone please have this background noise can mute himself, please. Okay, if I have a distal fistula, so it should be low output fistula, and it is coming after a reversal of colostomy, like after suturing or stapling, so it will be small fistula. And as there is no infection and as there is no distal obstruction, 90% of fistula will close spontaneously. In low output fistula or distal fistula in the colon, as there is no distal obstruction and there is no infection in the fistula or in the ostium or in the skin covering the fistula, as there is no infection and as there is no distal obstruction, 90% of fistula close spontaneously. So this patient have a distal colocutaneous fistula, no distal obstruction or no anastomotic stricture, so no obstruction or stricture. So what you will do, you will provide local wound care with antibiotics to guard against infection, with waiting for spontaneous resolution. Okay? Next question. Dr. Sarah, unmute yourself.
73 years old lady present with peritonitis and tenderness of the left groin. At operation, she had the left femoral hernia with perforation of the anteromesenteric border of the ileum associated with hernia. What type of hernia is in this? She had Letters hernia B.
Letters hernia. Different answer. Anyone has another answer?
The question, part of the intestine. Okay.
Okay.
Okay,
So
Dr.
which
Sarah,
hernia?
so it will be rectus hernia, not letters.
Which hernia have, yes, which hernia will have a part of the intestine, a part of a wall of an organ? Richter's hernia. Okay. We have two types of just some sort less common types of hernia. Okay. One hernia is called Richter's hernia. Richter's hernia. And this is a hernia which will include part of the wall of the organ. So if I have, this is the opening. So I'll have something like this. And this is the rest of the organ. So I'm having just part, okay, with different color. So I'll have just part of the wall in the hernia. So that's what's called Richter's hernia. Also, what is Letters hernia?
It's present on the
Michels.
Yes, exactly. This is hernia of Michels. Michels.
I mark it with LM.
Maybe, yes.
Yeah.
So,
okay.
So Letters hernia is Michels diverticulum inside a hernia. Okay, so this is called Letters hernia. The other hernias we discussed, we can take also splenian hernia. Splenian hernia is hernia through the rectus abdominal sheath. Rectus abdominal sheath, maybe on the lateral edge or in the arcuate line, you will have hernia. So this, any hernia in the lateral rectus sheath coming from the abdominal wall, it's called splenian hernia. So splenian hernia, it is the right name of Okay. So this is part. So the patient is complaining of just part of the antemesenteric border of the ileum associated with the hernia. So this will be Richter's hernia. Okay, next question.
Okay.
Sorry, Dr. تفضل.
I need to put 2 points for previous question. Amide hernia appendix.
Amide hernia, exactly. But we didn't say, I know it, but I didn't see any question. So we have many here, not surgeons. So I don't want to confuse them with more names of hernia.
Okay. Okay.
Okay, that's why I know the hernia and diaphragmatic. And also I just was also postponed the 2 other hernias, Morgagni and Buctalic hernia, for their question, so they don't get confused.
Okay.
So now just we have Richter's hernia, Lettres hernia, and Splenian hernia, because these 3 will find questions we'll face today. Okay?
Okay.
Thank you, Dr. Dafir.
Thank you.
Okay, next question, Dr. Dafir. Okay, you can go.
In which of the conditions described below Ravsing sign most likely to be present? Local advanced cecal carcinoma, para-ileal appendicitis, right side colic diverticulitis, retrocecal appendicitis, and severe terminal ileal Crohn's disease. So Ravsing sign, it's for appendicitis. For this, it is retrocecal appendicitis.
Okay. So read the question again. Ravsing sign most likely to be absent.
Oh, absent. Okay. Absent. It's for terminal appendix diverticulitis. Okay, severe terminal ileal Crohn's disease. No, it's present. Local advanced cancer. Local advanced cancer. Right side colic diverticulitis. Okay.
What is Ravsing sign?
Ravsing sign, the deeper pressure for the right side would get the pain in the right. Yes.
Okay, compression on the left colon, left side of the abdomen, or left iliac fossa, or left side of the abdomen will push the colonic contents to the right side and will elicit pain. Okay, so compression on the left will elicit pain on the right. All these conditions are right-sided conditions. Advanced cecal cancer right side, para-ileal retrocecal appendicitis right side, severe terminal ileal Crohn's disease. This is terminal ileitis with tumamic appendicitis. The only one I have on the left side, which is right colonic diverticulitis, and this will give a rebound tenderness.
Yes.
Tenderness and rebound tenderness at the site of the pressure. Okay.
Yes.
Clear now why you did choose this answer?
Yes.
So, sorry, retrocecal appendicitis. What did you answer in the start? Retrocecal?
I will say here retrocecal appendicitis, yes.
Okay, I have to see this question again. Any advanced right iliac fossa surgery can result? Sorry, a minute, please. I just have an important phone. Minute, please. Excuse me.
Okay.
Okay, back. Sorry for this disruption. Okay, let's read what is written here. Any advanced right iliac fossa pathology can result in post-operative sign. Okay, however, in retrocecal appendicitis, it may be absent, and this fact can contribute to delayed diagnosis if undue weight is placed on the presence of sign it's making.
Yes, it is true because
Yes, right-sided diverticulitis. Right-sided diverticulitis. So retrocecal appendix, yes. This is a little confusing. So I just read diverticulitis, which it will be most common on the left side. So right-sided diverticulitis, I didn't see before, or
because
I just...
yes, because it is very rare diverticulitis in the right side. Also, the retrocecal is the pathology below the cecum. So when the pressure on the left side,
yes, exactly.
not
Exactly. So retrocecal appendicitis is the by the way, this is a confusing question. I don't think that it may come in the exam. Maybe, but just okay. We can keep it retrocecal appendicitis, but questions will be more easier and more simpler than this. Is you are right. Sorry for that. Just confused. Thank you. So go for next question, Dr. Zaina.
Okay. 8 years old boy present with a 4-hour history of right iliac fossa pain with nausea and vomiting. He has been back at school for 2 days after being kept home with a flu-like illness. On examination, he is tender on the right iliac fossa. Although his abdomen is soft, temperature is 39.3. Blood test shows CRP of 40 and white blood cells of 8. What is the most appropriate course of action? Abdominal MRI scan, abdominal CT, diagnostic laparoscopy, active observation, colonoscopy.
Yes, many answered it right.
I think هنا يعني ما فيش الوايت disease not elevated. Okay. يعني we can do observation. ممكن تكون mesenteric colitis.
Okay, exactly. And was okay. Why he did mention for the patient with a flu-like illness?
To give hints for the mesenteric lymphadenitis.
Yes, any word is written in your scenario is very important and give you an idea. That's why he just treated. The patient will have a flu-like illness. By the way, we will face about 10 scenarios with right iliac fossa pain with different keywords. Okay, so roughly any right iliac fossa pain in a young patient, it is acute appendicitis until proved otherwise. Okay, young patient, 20, 13, something like this, mostly in 16, 17, 18, 20, 25, something like this. So it's acute appendicitis until proved otherwise. Otherwise, like give you a different scenario. So the typical scenario, right iliac fossa pain with rebound, sometimes nausea, and sometimes tachycardia, mild fever, and gives a history of rebound. This is a typical history of appendicitis. Okay. If he gives you the same picture with a patient about 60 years or 50 years, old patient or patient over 50, so your first doubt is cecal cancer. Cecal cancer. So he can give you simply the same picture, right iliac fossa pain, tenderness, and the patient is more than 50, and he will give you another hint like the patient is anemic or his hemoglobin is 9. So this is a problem and causing some sort of anemia, so you have to investigate. Okay?
Okay.
This is one of the two options. Many options, others like right iliac fossa pain in a female patient, and he will mention that she has last menstrual period 2 weeks ago and her pregnancy test is negative. and he will ask you, what is this pain? So what is the importance of telling you that the last menstrual period is 2 weeks ago, that she have now in the mid-cyclic time, at the ovulation time. Also, he was just want to confirm with you her pregnancy test is negative. So it is not ectopic pregnancy. See, that is what we call mid-cyclic pain due to rupture of ovarian follicle. Okay? Another scenario with the same girl, and he will tell you the patient is shocked with severe pain and vaginal bleeding. So he didn't, yes, so this is disturbed ectopic or rupture ectopic. He will not mention that the patient, he didn't mention that the patient has negative pregnancy test. Another scenario with, I just collected most of them. What we said before about right hypochondrial pain plus right-sided or pelvic pain and vaginal discharge. And this will be PID associated with Fitz-Hugh-Curtis syndrome. What's more tiny scenarios for right hypochondria? Types, colonoscopy, so okay. Another scenario in a young patient, young boy, with right iliac fossa pain, which is intermittent for a few months, and the patient has done colonoscopy and upper endoscopy, and the patient is free. So what will give you right intermittent pain in the right iliac fossa, and will give you an upper and lower endoscopy free in a young patient? This will be Meckel's, mostly suspected Meckel's diverticulum. Okay?
Okay.
Another scenario will give you right iliac fossa pain, intermittent, and the patient has diarrhea and loss of weight. So what you suspect? Crohn's disease or inflammatory bowel disease because of terminal ileitis, which will make for you mimics the picture of acute appendicitis. So this will be inflammatory bowel disease. So all these scenarios you will find about right iliac fossa pain. Some with bleeding, some with discharge, some with intermittent for long time, some with diarrhea, some with mid-cyclic pain, some associated with right hypochondrial pain. All these scenarios, this is keywords in every scenario we will face. Now I hope we can reach this question so you can differentiate between all causes of right hypochondrial pain. Okay?
Okay.
Clear, or I get you got lost from me?
Oh, it's clear for me.
Clear.
For you, okay. So who's next? Dr. Sarah?
Me.
Dr. Sarah, unmute yourself. Next question.
A 6-day-old child is suspected of having malrotation require urgent abdominal exploration. What is the most appropriate surgical approach? Midline abdominal incision.
No.
What's the common practice for a child? Mostly than 1 year or up to 2 years. Incision, exploratory incision.
Due to the time direction of the muscle.
As an incision for intussusception, Dr. Sarah.
it's for malrotation.
I know, but I'm talking that it is the same incision.
No, it may be sometime yes or no.
No, I don't know.
Could you explain that?
What?
I could explain for all. For pediatric age groups, especially lower than, less than, do you hear me? Less than
Yes.
2 years, less than 2 years, all transverse supra-abdominal incision, supra-umbilical incision. For intussusception, it is preferable to do infra, but we can do it supra.
Hello, it is clear?
Yes, now clear.
Yes.
Okay, sorry, just I have a minute, please. Okay.
Someone eating Doritos.
Okay.
We hear the voice.
Who's eating? No one is eating. Yeah. Okay. Who's next?
Okay.
Dr. Zaina?
A 4-year-old girl admitted with lethargy and abdominal pain. On examination, she is febrile, temperature 38.1, pulse rate is 150, and the blood pressure is 100/60. Her abdomen is soft, but there is some right-sided peritonism. Her white blood cells is 14, and urine analysis is positive for leukocytes. What is otherwise normal? What is the best course of action? Manage as UTI infection with oral antibiotics. managed as urinary tract infection with intravenous antibiotics. Take two-seater for appendectomy within 6 hours. Undertake ultrasound scan. Admit for serial clinical examination. هو يعني هنا signs acute abdomen, so urgent operation.
Exactly. This is a young girl or a child coming with history, some fever, temperature, tachycardia, blood pressure almost normal. Her abdomen is soft, but there's right-sided peritoneum. So it is clearly, as I told you, he will tell you clearly there is right-sided peritoneum and tachycardia and all signs of acute appendicitis. So acute appendicitis will be the main diagnosis, and this in a child, you don't have to wait, and it is not practical to wait because the child has a less protective path and less protective short omentum, and rupture appendix and complicated appendicitis is very common to happen. So in a child, you shouldn't wait for appendectomy if you suspect appendicitis. Okay.
Okay.
Dr. Abu Yazid was asking about the incisions. Okay, so just what we'll need here, we will face in our discussion some incisions like Kocher incision, which is incision we'll do always for open cholecystectomy. Lance incision. This is the transverse incision for appendectomy, which is the gridiron incision, which is the right iliac fossa incision, oblique incision. This is the abdomen, right iliac fossa, and this is hypopendulum. So this is Kocher incision, and this is gridiron incision, and this is Lance incision, which is transverse right iliac fossa incision, and sometimes what they call bikini incision, because it's more cosmetic for girls and females. The other one is finished teal, and this is the gynecological incision, and we will not. Yes, one important one, we'll also face one question is MAC-FD incision, which is an inguinal incision extended to subinguinal ligament. That's for strangulated femoral hernia. The other one is Rutherford-Morrison. Rutherford-Morrison incision
For transplant.
is the, sorry?
For transplant, yes.
Yes, for transplant, and sometimes we do it for appendectomy when we find a high appendix or a subhepatic appendix. We just make this the incision, or this is the incision. This is an extension, what's called Rutherford extension. So this is will be the picture of the incision will be like this or like this. We start with this and extend in subhepatic appendix. Sometimes the appendix is high up, subhepatic, or on the beside the right flexure, and this is what's called Rutherford extension. And the other one, which we use it, is for renal transplantation to assess the kidney and the ureter and the bladder. So this is Rutherford incision. Another incision which is called, where is it? It is not here. Roof top incision. Okay.
Yes, present cable.
Sorry?
It is the same name or cable. Cable.
Cable name?
Yes, it is.
Yes, yes, here, yes, rooftop incision.
Yeah.
Rooftop incision, which is an incision we use for sometimes for a hepatic transplantation, and sometimes we use for Weibel operation. Okay. Any upper GIT big surgery like Weibel or hepatic transplantation, liver transplantation, we use what's called rooftop incision. Clear? Just names, and we will be asked about the names for this incision. We will face this question in our discussion. Okay. Next question, Dr. Who's turn? Dr. Doffer?
Yes, okay.
Okay. Dr. Doffer, okay.
Yes, but I'm starting where about, I'm waiting for question. Where is the question?
You can't see the question?
No, just the treatment, appendicectomy, which can fix on this. Okay.
You can see it now?
Yeah. 14 years female,
okay,
with sudden onset right iliac fossa pain. She is otherwise well. On examination, she has some right iliac fossa tenderness, but no gardening. She is febrile, urine dipstick is normal. Her previous menstrual period 2 weeks ago was normal, and pregnancy test negative. What is the most likely underlying cause? This is A, multisystem MERS, endometriosis, appendicitis, Crohn's disease, one pelvic. So it is A.
What's meant by A?
Yeah.
Mid-cyclic pain.
Yes.
Okay, so young girl, fertile. Just she said 2 weeks ago, the last menstrual period, so she is in the mid-cyclic period. So this is what is called, I think this word is Deutsch word, which, because you have Schmerz.
Yes.
Schmerz is pain by German or by Deutsch, so it is I think it is Mittelschmerz syndrome. This is what's called mid-cyclic pain for young female. And this is also one new question for the right iliac fossa pain with negative pregnancy test, and also last menstrual period 2 weeks ago with no vaginal discharge. Okay, next question, Dr. Zaina.
Okay. 12-month-old child is brought to the clinic with a history of right groin swelling. The parent have a photograph on their mobile phone, which looks very much like an inguinal hernia. What is the best course of action? Okay, arrange an MRI scan, undertake an open inguinal hernia repair with mesh, undertake an open inguinal herniotomy, undertake a laparoscopic hernia with mesh, arrange a herniogram. هو طبعا في البيدياتريك we do herniotomy. اوكي بس مش فاهمه السيناريو يعني why photograph موبايل يعني why not doctor.
Okay, most cases if you work in pediatric surgery, some sorts of infantile inguinal hernia or scrotal hernia in a child, it has a communication with the peritoneum. So the child, when crying or when stressed at home, it appears, and then the child, when he is calm, it's complete disappearance of the swelling happened. And the only thing that you can discover or you can depend on in your diagnosis is a picture from the parents that will give you, he will tell you, the parents will give you, we take a picture from the child, and I have seen, I did see that many times before, and the child in the clinic is completely normal. I just sometimes I want him to cry or stress or stand up for a time and then appears, but the most dependable sign it will be the parents will take a picture while the patient is, the child is crying or straining, and it will appear, and at this time will disappear. And this is some sort of infantile communicating hernia. That's the hernia, the vaginal hydrocele is communicating with, attract with the peritoneum, so it is filled with peritoneal fluid and empty again. So that's an infantile or congenital infantile hernia. So what's your action for a patient with inguinal hernia in a child? What's your management? Herniatomy. Okay, so we have only one herniatomy. Okay, so undertake an open inguinal herniatomy. So what we have now, we are going to illustrate. We have inguinal hernia in a child and in adult. In adult, unilateral and bilateral. Okay. In a child, what we do? We do herniatomy.
Herniatomy. Adnomish.
Okay.
Adnomish.
With nomish. Herniatomy, not hernioplasty.
Yes, yes.
Herniatomy.
Yes.
Okay. I can see some.
A lot of friends, we didn't saw the question.
Can see the question.
For me, yes. But
who else? Who else can see the? Who else can see? Yeah, I can't. No picture. No picture. I see the previous. I can't hear you well. Okay, I close and share again. I close the sharing and share again. Okay.
Okay.
Okay. Is it clear now?
For me, yes.
Okay. Dr. Abul Yazid. Dr. Az. Okay. Sorry, maybe some maybe some connection, not more. Okay, what we are was saying that we have hernia like this. We have the hernia and inguinal hernia in child and adult, and this is two types, maybe unilateral or bilateral. And we have in a child or infant, whatever. In a child, what we do herniotomy.
Herniatomy.
Herniotomy, which is just ligation and cutting of the sac. We don't do hernioplasty, which is applying a mesh or something like this. This is in a child. In adult, we do hernioplasty. Hernioplasty. Hernioplasty means I just make herniotomy plus mesh. I remove the cut and the hernia and apply a mesh on the posterior abdominal wall. according to the UK policy, if it is unilateral, you will go for open hernioplasty. If it is bilateral or recurrent, you will go for laparoscopic hernioplasty. Clear?
Yes.
Clear for all? Okay. Okay, next question. Who is ready?
I'm ready. Okay.
Okay.
Start.
Okay, start.
1 day old infant born with a severe respiratory compromise. On examination, he has a scaphoid abdomen and absent apex peat. What is the following anomaly is the most likely? Situs inversus, Morgagni hernia, necrotizing enterocolitis, Bugdalic hernia, and cystic fibrosis. It is actually a Bugdalic hernia. We get it from 1 day, scaphoid abdomen, absent apex,
Yes.
deviated to the other side. So it's the Bugdalics. Morgagni later on, less severe.
Okay. Let's simplify the difference between this and so this is sort of diaphragmatic hernia. Okay, congenital diaphragmatic hernia. Okay, this is sort of congenital diaphragmatic hernia. We have two congenital diaphragmatic hernia. One is called Morgagni, and what's called Bugdalic hernia. Okay, what is the main difference and the main keywords in the scenario? Morgagni will take the G and say it is a good hernia. Bugdalic will take the B and which is a bad hernia. Bad hernia, which is very severe hernia with bad prognosis. Good hernia is a simple small hernia. Okay. Morgagni hernia, as it is a good, so it appears later in life with little complications, like little respiratory compromise. Bugdalic hernia, as it is a bad hernia, it appears early in life from the first day, like Dr. Duffer said, scaphoid abdomen, and herniation of a big part of the abdominal contents inside the chest with hypoplasia of the ipsilateral lung. So it's a bit, by the way, Bugdalic is a big defect. So in the big defect will be herniation of a big part of the abdominal content inside the chest, more on the left side, So it will be compromise the chest and the respiratory system and makes hypoplasia of the ipsilateral lung. For the Morgagni hernia, if defect is small, through the Morgagni opening and appears later in life with no respiratory complication. So if he told you just appeared after 3, 4, 6 months and you found a small hernia in the chest with no respiratory complication. So it is a Morgagni good hernia. If he tell you that is a big hernia from the first day and the patient has respiratory distress and compromised chest and the patient has scaphoid abdomen, so it is a bad Bogdalic hernia. Because it's bad, so it goes in the left side, more common in the left side posteriorly, and Morgagni hernia, as it is good hernia, so it goes on the right side of the diaphragm. Is it clear?
Okay.
Hello?
Hello.
Any answer? Answer in chat. It is clear? I think it's simple, yeah? Dr. Az, unmute. Dr. Sarah, unmute. Okay. Is it clear for all?
Yes.
Okay. So go with Dr. Sarah. Okay.
25 years old lady with 12-hour history of acute constipation, vomiting and colic abdominal pain. On examination, her abdomen is distended and she has right-sided tenderness. Imaging demonstrates an obstructing hepatic fracture tumor with Sickle diameter 11 centimeters. What is the best course of action? Resuscitate with intravenous fluid.
What's your answer? B or C?
B. يعني في antibiotic and intravenous fluid. C.
B or C?
For me,
C.
B.
C.
For Dr. Sarah.
C for
Dr. Ibrahim, B.
antibiotic
Dr.
intravenous
Zainab.
fluid.
Okay, just a minute.
You have 40 seconds in the exam, not a minute.
Okay. هو هنا السيناريو فيه obstruction. اوكي.
Few obstruction,
So
vomiting,
I will
colic
choose
abdominal
B.
pain, absolute constipation. You'll choose
I will
B.
choose B.
Okay, for sure. The patient is coming the patient is coming for an emergent surgical case. But the patient has vomiting, colic abdominal pain, absolute constipation for 12 hours. So the patient is dehydrated and has metabolic disturbance and has electrolyte disturbance. So what will you do for this patient? You have to relieve. By the way, what is the normal cecal diameter? Up to
8.
Up to 8 centimeter, it is safe for you. More than 8 centimeters, so it is impending rupture of the cecum. So you have an emergency case. Within few hours, you have to start your operation. Okay, laparotomy, but you have to resuscitate your patient.
Yes.
Patient should be resuscitated, and the resuscitation fluid is given within 1 hour. So you will give resuscitation fluids with 1 or 2 hours and then go direct for laparotomy to save the cecum from rupture.
And this is very important sentences. The son should not rise and sit on unrelievable large bowel obstruction. This is very important.
Exactly. This is very important. Yes. The son shouldn't rise and sit on unrelieved large bowel obstruction. Very important sentence, they always say in UK and all worldwide for any sickle or any chronic obstruction. Clear?
Yes.
Anyone stopped or something not clear with him can raise hand, please, before we continue. Dr. Az, unmute yourself.
I'm following. Doing fine.
Sorry?
I'm following. I'm doing fine. Thank you.
Okay. So, whose turn?
For me?
Go for Dr. Dr. Zaina. Dr. Zaina, and then you start again.
Yes. Okay.
Go.
11 months old girl develops a sudden onset abdominal pain. She has a high pitched scream and draws up her legs. Her blood pressure is 90/40 millimeter. Her pulse 118 per minute, and abdominal examination is normal. What is the most likely diagnosis? Mid-gut volvulus, intussusception, appendicitis, mesenteric adenitis, spontaneous bacterial peritonitis. هو مش مدي داتا كتير يعني.
No.
Okay, what you suspect here?
بس
What you
هي
suspect and what you exclude?
البين مع الاليفيشن اوف ليجز ده ماشي مع الانترسبشن.
Exactly. This young child always come about from 9 months to 1 year, or from 7 to 8 months to 9 years, when the child start to eat food. Okay, so the child is very susceptible for mesenteric intussusception, mesenteric adenitis from just entering some new food or something like this. So it's a very common age for intussusception. Also, the patient screaming from pain, squeezing pain, and draws his leg up in his abdomen to relieve the pain. And this is very common with intussusception. Sometimes he will tell you there is red currant jelly stool found in diaper or in the stool. Okay, so if he didn't say, but he just said screaming or cramping or pulling his legs on his abdomen, so it is very common and very pathognomonic for intussusception. Midgut volvulus, I think it comes more early in life, not at 11 months. Appendicitis, not this pain. Mesenteric adenitis, he will not scream. Spontaneous bacterial peritonitis, there is no fever associated. So intussusception is our right answer.
Okay.
Next question. Okay, Dr. Dafer.
Okay. Which abdominal sign is described as being presented with the patient with cholecystitis experience pain on the palpable of the right upper quadrant, most markedly on inspiration? Marfan, Booz, Ravzing, choline, Grays, it's Marfan.
Exactly. We said that cholecystitis is very common with Marfan and which other sign? Bowel sign, exactly.
Bowel sign. Okay.
Yes. And this is the next one here. Okay, next question, Dr. Shi.
Of the surgical incisions listed below, which is most suitable for a 45-year-old female undergoing a first-time renal transplant? The D. Rutherford Morrison incision.
Exactly, we just said. That's all about incisions, by the way. It will come clear. You just know what's incision for each operation, so it will be clear. So this is Rutherford Morrison incision. Next question, Dr. Sarah.
A 50-year-old female present to the emergency department with 12-hour history of pelvic discomfort. She is otherwise well and her last menstrual period 2 weeks ago. On examination, we have this before. Metal skins. Some mild she was likely undergone cold. Metal skins. Is this a recurrent question? I think.
Repeated question, you mean? She is otherwise well and she's last menstrual period 2 weeks ago. On examination, she has soft abdomen with some, so it is not appendicitis, soft abdomen, just suprapubic discomfort. Okay, so it is a PID or not PID. The PID will come with the dyspareunia and exaggerated with cervical movement. So just he tell you 2 weeks ago. So he meant that you want to know this is ovulation time. So this is the Mittel-Schmerz syndrome or Mittel-Schmerz pain. Okay. Let's see the answer. All said DD, Dr. Rez E, Dr. Duffer E, exactly. Okay. So it's clear now to know what's 2 weeks cyclic pain, 2 weeks last menstrual, so it is a cyclic pain. Okay, next question, Dr. Duffer.
Yes. An 8-year-old boy is examined by his doctor and part of routine clinical examination, the doctor noticed a smooth swelling in the right iliac fossa. It is immobile, he is otherwise well. What is the most likely underlying cause? Microbiology, Swigilian hernia, mesenteric cyst, appendicular mass, liposarcoma. It is mesenteric cyst.
Yes, exactly. This is the only thing inside the abdomen which is mobile swelling. Okay, Michel's diverticulum, it is not swelling. Splenic hernia is not mobile. Appendix mass is not mobile. Liposarcoma will not mobile. Mesenteric cyst will be mobile cyst because it is a cyst in the mesentery and it moves with the mesentery. And one of the cardinal signs of mesenteric cyst is it moves with the axis across the axis of the mesenteric root. Okay?
Okay.
Next question, Dr. Zaina.
Okay. 84-year-old lady present with a tender painful lump in the right groin and signs of a small bowel obstruction. What is the most appropriate surgical incision to address this problem? Leucism, McEvedy, midline abdominal, paromedian, Kocher incision. McEvedy. The case like femoral hernia.
Okay, so old lady's lump in the groin region. So it is McEvedy incision for incarcerated
I don't
femoral.
know what is the meaning of the first choice. Leucism, I don't know.
Hey, I think this is Leucism hernia, but he made the T, I think.
Okay.
He lost Leucism hernia, maybe because in few next questions you will find it completely correct. The same like Leucism hernia, Liechtenstein hernia or something like this. I don't know if it is something.
Liechtenstein repair. Okay.
Maybe yes. So we don't care. We just need what we will be asked about. Okay, next question, Dr. Shi.
A 19-year-old lady is admitted with lower abdominal pain. On examination, she is diffusely tender. A laparoscopy is performed, and at operation, multiple fine adhesions are noted between the liver and abdominal wall. Her appendix is normal. What is the most likely diagnosis? It's B, Fish-Hurd-Curtis syndrome.
Exactly. It's an easy question and repeated as well in different times. PID with right hypochondrial pain. So sometimes the PID comes with right hypochondrial pain. So it is Fitz-Hugh-Curtis syndrome associated with pelvic inflammatory disease. Okay, next question, Dr. Sarah. Okay, Dr. Sarah, unmute yourself.
21-year-old woman is admitted with a 48-hour history of worsening right iliac fossa pain. She has been nauseated and vomited twice. On examination, she is markedly tender in right iliac fossa with localized guarding. Vaginal examination is unremarkable. Urine dipstick, including beta-HCG, is negative. Blood tests show a wide disease of thirst and wrath and C-reactive within 70 is the most appropriate course of action.
What is your diagnosis first?
Appendicitis.
Okay, so typical picture of appendicitis, and he cancels with you. He tell you vaginal, no vaginal discharge, so it is not PID. No bleeding per vaginal, so it is not ectopic, and urine dipstick, including the pregnancy test, is negative. So he just direct you to the diagnosis of acute appendicitis. So what's your action for acute appendicitis in a young girl or a young woman?
Open appendectomy. Laparoscopic appendectomy. Sorry.
Yes, exactly. So laparoscopic is now made for cosmetic purposes for females, young age female. So it is the most acceptable now in UK, most of the world, by the way, to make it is made mainly for young girls, like cosmetic operation. So it is laparoscopic appendectomy. Okay.
Yes.
Okay.
Next question again, Dr. Dafir.
Which of the following sign is seen in the patient who have a significant retroperitoneal hemorrhage, opposing both sign, pamper turn sign, gray turn sign, blue sign, ravaging signs. This is a green turn sign. C.
Gray turn sign, exactly. Next question, Dr. Zaina. Dr. Zaina, unmute yourself. Okay, Dr. Shi.
What type of stoma should be considered in a patient undergoing emergency operative intervention for large bowel obstruction as a result of a carcinoma 5 cm from the anal bulge? It's B, a loop colostomy.
Yes.
Exactly, yes. As we said before, an emergency situation for obstructed bowel, especially last distal colon and rectum and anal canal, you have to relieve obstruction by just loop colostomy. It is a simple operation. Extraperitoneal sometimes be done. You just open a small incision and grabs the colon and make the incision and suture it to the abdominal wall. So loop colostomy is very easy to do for a patient till resuscitate the patient and reach to your definite diagnosis and definite treatment. Okay, next question. Dr. Zaina, ready? Okay, Dr. Sarah, okay, unmute yourself.
A 43-year-old man has suffered from small bowel Crohn's disease for 50 years following a recent strictureplasty, developed an enterocutaneous fistula, which is high output. Small bowel follow-through shows it is a P50 cm from the DJ flexure. His overlying skin is become excoriated. What is the best course of action?
So this patient
High
has
output fistula, high output fistula.
high output fistula and in a proximal site. This is just 15 centimeter from the DJ. Sorry?
E, perform a small bowel bypass procedure.
No. You're going to do a bypass for a fistula. It's a very big operation, the bypass, by the way. Okay, Dr. Tamer, good. Dr. Dafir, Dr. Shi, Dr. Az. Okay.
For this, yes.
All of them answered C, and that's right. This patient is susceptible and high risk for getting dehydration and metabolic and electrolyte disturbance from the high output fistula, which is almost always just 15 centimeter from the DJ. That means that all of the food and the fluids coming by mouth, it all will be secreted through the fistula, and the patient can get deteriorated in very short time. What will you do? You should stop the patient food, and the patient should be near per mouth, MPO, and you will commence for a TPN for feeding with octreotoids, which is a synthetic somatostatin, which will help to decrease the secretions of the GIT. Okay?
So,
Clear?
yes, clear.
So this patient is mainly, you have to stop, the patient is main treatment NPO, and they give something to decrease the secretions of the GIT. Next question. Dr. Dafir, okay.
Yes. Which of the following strategies is not employed in the management of the bleeding esophageal varices? Endoscopic sclerotherapy, intravenous vasopressin, intravenous beta blocker, endoscopic rapid ligation of the varicosis, insertion of zingistatin tube. I prefer it is intravenous vasopressin.
Your answer is?
B.
B,
Yes.
intravenous vasopressin. We don't, it is, by the way, it is not employed in the management. So all of the following we use in management of esophageal varices, except for vasopressin. So are giving beta blockers to a patient with esophageal varices.
Yes.
And also you give vasopressin. Okay, the wrong one here is intravenous beta blocker. Intravenous beta blocker we use before the varicella start bleeding. We just use it to decrease the portal venous pressure. Okay, used to manage, but it is not used to manage acute event. But vasopressin, we use it. Sclerotherapy and dam ligation, we use it. Simvastatin or Blackmore tube, we use it as well. So we don't use beta blockers as acute in the acute station. We use it on the long run before to decrease the intra or decrease the portal venous pressure, so decrease the chance of bleeding. Clear?
Yes.
Okay, next one. Dr. Zaina.
Okay. 22 years old man operated on 4 left inguinal hernia. At operation, the sac is opened to reveal a large Meckel's diverticulum. What type of hernia is this? Meckel's diverticulum letters hernia.
Exactly. This question don't take more than 10 seconds from you in the exam. Okay. Meckel's is letters hernia. Next question, Dr. Shi.
Which of the following agents increase the rate of emptying of vagotomized stomach? Rate of erythromycin.
Exactly. It's a repeated question in physiology, by the way. Okay. Yes. Some of your friends sent me before a question like I think it's in recalls, so I have to mention. Okay, he said just it was from the EMQ question, extended matched questions, the old extended matching question which came before, and he gave him 3 options, which is erythromycin, metoclopramide, and Honda, and Zirone. We use it like Honda, and he give him 3 scenarios, and he tell him choose the drug, best choice for the drug in this scenario. So first scenario was which drug is working on the vomiting center in the brain.
I saw that.
Sorry?
Yes.
Which drug of these 3?
Ondansetron.
Exactly. This suppresses the vomiting center in the medulla, in the brain, in the midbrain, I think, in the medulla, yes. So it stops centrally stops the vomiting, or that's in cases of sometimes like motion sickness and labyrinthine stimulation of the vomiting. Then the next question, which drug is used in patient with diabetic gastropathy? Diabetic gastropathy, complaining of vomiting.
Erythromycin.
Exactly, erythromycin. Diabetic gastropathy equal vagotomized because it is a neurological condition affecting the vagus nerve, causing diabetic gastropathy. So diabetic gastropathy or vagotomized patient, you will go for erythromycin. The last question was, by the way, in EMQ question, you can choose the same answer twice or 3 times, more than time. The third question was, patient was bleeding esophageal varices. Okay, bleeding esophageal varices plus vomiting. What is the best drug choice?
Ondansetron.
No. Anyone knows?
Bleeding.
I answered it in the group before.
Yes.
The best drug in bleeding esophageal varices plus vomiting, and sometimes it is given as a routine in management of bleeding esophageal varices. Not erythromycin, no.
Diclofenac.
You have three choices here.
Yes.
Ondansetron, I said no. Erythromycin, I said no. Metoclopramide. Metoclopramide. Do you remember the action of metoclopramide?
Yes.
Okay, it is antiemetic. Okay, it is antiemetic, which increase the lower esophageal sphincter tone to prevent vomiting. So by this way, I decrease the blood going to the stomach and absorption, and decrease the incidence of hepatic encephalopathy from absorption of blood, or encephalopathy which are from absorption of blood in the stomach. Okay, so the best drug given in vomiting with bleeding esophageal varices is metoclopramide, because it increases the lower esophageal sphincter tone, so prevent the blood from going from the esophagus to the stomach as well. Clear?
Yes.
Is it clear, or someone wants to ask about anything?
In this equation, if we remove, if in this equation, when we remove the vagotomy, we should change the choice to the metoclopramide for this.
No, metoclopramide do its action through vagus nerve.
Yes.
Vagotomized patient or diabetic gastropathy, the patient which has non-functioning vagus nerve, you can't give metoclopramide. Metoclopramide its action through the vagus nerve.
Yes, but I said the verse to that, if we remove the vagotomy from the question, so it is not vagotomized, so we change from the erythromycin to the metoclopramide in the last question.
Yes, exactly, yes. Metoclopramide is the boss, is the most common drug used in a normal stomach. Okay, but its action through the vagus nerve. So in vagotomized patient or patient with diabetic gastropathy, we don't use metoclopramide, we use erythromycin. And in patient with bleeding esophageal varices, metoclopramide is used because it's increase the lower esophageal sphincter tone. Okay, next question, Dr. Sarah. Dr. Sarah, unmute yourself. Okay, Dr. Dafer, go again.
At 25 years old, Bildar presented with the reducible swelling in the right groin. It's become large and has not been operated on previously. What is the best course of action? Open inguinal herniatomy, laparoscopic inguinal herniatomy, open Bassini repair, laparoscopic Bassini repair, open lesionistic repair. It is the unilateral bigs. It can choose either laparoscopic inguinal herniatomy or open lesionistic repair. So for this, it's big, and I choose the laparoscopic inguinal herniatomy.
25, you'll do a herniotomy.
No. Oh, it's E, open lesionistic repair.
Okay. Liechtenstein repair.
This is the...
Okay, we said only unilateral. We'll go for open hernioplasty. Okay, Bassini repair is an old operation with high recurrence rate. And laparoscopic surgery, we use it only for bilateral or recurrent. Hernia. Open inguinal herniotomy is unacceptable in adult person. Next question. Dr. Zaina, okay.
78 years old lady present with colic abdominal pain and tender mass in her groin. On examination, there is a small firm mass below and lateral to the pubic tubercle. Which of the following is most likely underlying diagnosis? Incarcerated inguinal hernia, thrombophlebitis of saphenopharynx, incarcerated femoral hernia, incarcerated obturator, deep venous thrombosis. هتبقى incarcerated femoral hernia يعني
Exactly. This is the same scenario. This is the same scenario. The last scenario. The 78-year-old lady, colic abdominal pain in the inguinal, but there is pain and tenderness in the inguinal. There is pain in the inguinal area radiating to the knee. There is no swelling, so it is an obturator hernia. But here he said pain and tender mass in the groin, and there is a mass below and lateral to the pubic tubercle. So it is a typical picture of incarcerated femoral hernia. Okay, next question. Dr. Shi.
Which of the following is not a typical feature of acute appendicitis? Neutrophilia, profuse vomiting, anorexia, low-grade pyrexia, small amount of protein on urine analysis. E, small amount of protein on urine analysis.
Sometimes happens with pelvic appendix, irritation of the bladder.
And then A, neutrophilia.
It's a very common feature.
So which one is not a typical feature? So I think it's E usually.
Okay.
Yeah.
Profuse vomiting. Okay, patient with acute appendicitis. For your practical work, the patient is suffering from anorexia. The patient will suffer from anorexia. And if the patient is eating within few hours, he will suffer from vomiting. Otherwise, it is a mild to moderate anorexia and loss of appetite. When you are taking a history from a patient with appendicitis, you just let him, if he didn't vomit, just ask him, do you want to eat or did you eat? He will tell you, no, I didn't eat or I don't want to eat. And he tell you, no, I can't smell food or something like this. Okay. So profuse vomiting, it is not a cardinal sign of acute appendicitis. And if you see a person or a patient with profuse vomiting, I think acute appendicitis sometimes may be excluded from this scenario. Okay.
Okay.
Okay. Let's go for last question for today. Dr. Sarah. Unmute yourself, Dr. Sarah. Last
25
question,
years
please.
old man is admitted with sudden onset severe generalized abdominal pain, vomiting, and single episode of bloody diarrhea. On examination, he looks unwell and uncontrolled atrial fibrillation, although diffusely tender his abdomen. What is the most likely diagnosis?
It's a vascular question, by the way. You didn't share with us who's vascular.
Mesenteric infection.
Yes, exactly. So this is an old patient and he has AF, and mostly sometimes in the scenario will tell you he was admitted or he is in the ICU or ITU, okay, and on anticoagulant and blood thinners. And then the patient, sudden onset of severe abdominal pain, vomiting, and passing a motion of bloody diarrhea. This is a cardinal sign for mesenteric infarction. Don't be confused with ischemic colitis. Ischemic colitis means just ischemia or infarction for the colon, and it's not responsible for diarrhea. Diarrhea comes from the small intestine. So mesenteric infarction of the small intestine, that will cause diarrhea for this patient. Okay? Clear?
Okay.
Okay. So we finished for today. I think more than half. We just only have 35 questions. We can finish tomorrow.
Yes.
Thank you for today. I'll close the recording, not to make the video so long, and any problem or any question you can ask me.